I'm muted. Okay, hi everyone. Can you hear me now?
Yes,
All right,
yes, yes.
awesome. My name is Professor Young. If you guys don't have me in class, I teach on Wednesdays, the 2 p.m. and the 5:30 p.m. section. So, what I was planning for us to do today for our review was play a Kahoot game, and just do some questions because I think doing some questions and practicing that is going to be really helpful for the exam. And then after the Kahoot, if you guys have anything specific that you want to go over in more detail, we can kind of just have a little bit of a discussion and open it up. I'm free until around like 6 p.m. my time, so we've got like an hour and a half. If you guys want to spend all of that time, we can. We'll just go until you guys feel comfortable and you feel prepared for the test. Okay? So let me share my screen. We'll get this Kahoot review going. And has everybody played Kahoot before? You guys know that how to connect on your phone and whatever. Okay. I'll show you if you have not. Okay, so you'll type in this URL here and you'll go to the website and you'll type in that game pin and then you'll see like your little character pop up here.
I'm gonna try. It wasn't letting me.
Yeah, no worries. Take your time. All right, I think everybody is in. So we'll go ahead and get started. Okay. This one gives you a time limit. I think it's like 20 seconds to answer, 15 or 20. So just do your best. We'll go over each question. Yes. Okay. So why would we want to notify our physician here? What is our normal fetal heart rate?
Like 110 to like 130?
110 to 160.
Once, oh, 160.
Close. Yep. So a heart rate
Okay, I'm confused on that, but I'll let you, I'll ask my question when we're done.
okay. So your fetal heart rate, your baseline is typically 110 to 160. That's a normal heart rate during labor, after labor, pretty much any time when we're assessing a newborn. If a fetal heart tone is above 160, we're going to be concerned because that is indicating that the baby is in distress. Okay. Typically, if the baby's heart rate is elevated, it can be related to like maternal infection. That's one of the things that'll raise or elevate a baby's heart rate. Or if mom has a temperature, baby's heart rate could go up. So anytime it's above that 160, we're going to want to notify the doctor. Okay. Checking mom's heart rate is not a bad idea because we want to make sure that we're not like, for example, that that's not mom's heart rate, right? Because that would be even more concerning. Like, why is mom's heart rate 174? Um, but typically, when we see an elevated fetal heart rate, it's because mom's temperature is high, not her heart rate. And then as far as like telling that the fetal heart rate is normal, we want it to be under that 160. So, what was your question, Josie?
Okay, so is this like just like for textbook, like NCLEX world, or is this like real world? Just because like I have five kids and I know with like 174, like my daughter was that like and I didn't have any temperature, I didn't have anything. I mean it would sometimes, I mean it would just kind of vary. I mean it never really went up higher than that, but like 150, 170, like 180 even and like they nobody's ever told me anything than that, but I just didn't know if that's
If that's
and
like,
I
so
because sometimes it goes up like that and they like I didn't get any kind of interventions.
yeah.
I just was curious just so I know like if this is what I need like for testing purposes, this is the answer.
So for testing purposes, yes, this is the
Okay.
answer. It's between 110 and 160. That's safe. Anything outside we would consider to be abnormal. I think for like in pregnancy and in the real world, this could easily have been you caught the baby at a point of time where the baby was having a really awesome acceleration, right?
Hmm.
So these kind of questions are tricky because it's not like you're getting an entire 10-minute fetal heart rate tracing where you can see, oh, yeah, baseline is 150 and we're excelling up to 174, which would be normal, right? But
Okay.
for the purposes of this, for the exam, if you're just given this information, go with that. No
Okay.
normal. But yeah,
Okay.
during the
I just want to
regular
make sure
baby.
like because when okay, just in my experience, like I'm an LPN and sometimes we have to do fetal heart tones in the ER. And
Mhm.
I'm like, I've had them like where they're like 170,
Especially if
160. And
they're
I'm
early.
like, what? And we sent them home. So I just want to make sure, like,
Yeah.
but thank you for clarifying that. Thank you.
Yeah, no worries. And also the thing to note here too is so like in the ER, whenever you're evaluating somebody who's pregnant, most of the time they're earlier than 20 weeks, right? If they're over 20 weeks, you're usually
Hmm.
sending them to labor and delivery. So
For the most part, yes. We
if
try to.
yes, so
We try.
anything earlier than 20 weeks, a fetal heart tone higher than 160 is normal. Babies' heart rates during gestation will decrease the closer they get to term.
Okay.
So like if you have a really early mom like who's only like 12 weeks and you put her and you just use your Doppler and you listen to her tones and her tones are 170, that's like not super abnormal for that gestation.
Okay.
Yeah, but this mom being 38 weeks, um we definitely want her in that 110, 160 range. But that's a really good question.
So should we make note like if they're 20 weeks or less that it's normal for it to be a little elevated?
If they're 20 weeks or less, I would be mad if the test asks you about fetal heart. Honestly, because you're not going to be tracing an earlier than 20-week mom.
Right. Okay.
So it's
Okay.
like
Sorry. I'm sorry for like
no,
going
it's
off track.
fine.
So
These are really good questions and you're thinking critically. So no need to apologize at all. But does that help clarify stuff?
yes. Yes.
Cool.
Thank you.
Yeah. All right. Let's move on to our next one. All right. So the correct answers for this were allows for fetal movement, maintains the body temperature of the fetus, surrounds, cushions, and protects the fetus. The only one is that it does not provide exchange of nutrients and waste between mom and baby. What would be doing that?
The placenta.
The placenta, you got it. Um,
And I got it
Oh, I
wrong.
didn't know we could pick more than one.
yeah, that's what
Okay.
the SATA, select all that apply. It's just it was
Oh,
abbreviated. So yes, that's what
okay.
that is. So for allowing for fetal movement, that amniotic fluid is basically the cushion that that baby moves around in whenever they're in utero, right? So it gives them a lot of movement and cushion around them that protects them. Um, that's same with like the yellow, the circle answer. Surrounds, cushions, and protects the fetus. Your amniotic fluid is also responsible for maintaining the body temperature of the fetus. So, our amniotic fluid does all three of these things. The only thing that it won't do is do the exchange of nutrients and waste, because that is primarily done through the placenta. Um, that allows for that. So, for the purposes of your exam, definitely know the roles of both the amniotic fluid and the placenta, for sure. All right, let me move this out of the way. Okay, so we're on our placenta here now. So, our placenta is the way that the baby gets food and oxygen, and it also provides exchange of nutrients and waste between mom and fetus. The placenta, the cushioning and protecting the baby is more for the amniotic fluid, and then preventing all antibodies and viruses from passing to the baby. That is not entirely true. Some things are still able to be transferred in utero from mom to baby. And typically we just rely on mom's immune system and that system to help kind of excrete like viruses and stuff and protect the growing fetus. But the biggest ones, as far as placental role, is that it's the way baby gets food and oxygen and it provides exchange of nutrients and waste. For the test too, I would definitely know or understand like how the blood flows between mom, placenta, umbilical cord, fetus, back out. Know which systems are carrying oxygenated blood to the baby and which systems are bringing deoxygenated blood out from baby. And
Can
then
you
also,
repeat that one more time? Like, so
yeah,
know the blood flow from mom to baby and
yes,
baby to mom?
yep, and know where like oxygenated blood goes to and from, and then deoxygenated blood, what carries deoxygenated blood away. Um, and then how many veins and arteries are there in the umbilical cord?
Two, two and one.
Two of which?
Two veins, one artery. No?
Yes.
Is it? Okay.
Good job. So yeah, know that stuff. And then because I definitely think that there would be some questions about that. Um, as far as structure. Okay. Hold on one second. Sorry, I have a student messaging me about my review session. Yep, so you got one vein, two arteries, okay?
Do we need to know
I don't know how to pause it. Oh no.
like that?
Sorry. Awesome. Great job. These dumb bars for the thing are getting in my way. Okay. The nurse is providing instruction to a client who's scheduled for an amniocentesis. What should the nurse provide? And you guys all got it right. An informed consent needs to be signed before this procedure. An amniocentesis is considered a high risk procedure, right? So this is something we 100% need consent for. What are some other things that we take into consideration whenever we're preparing a mom for an amniocentesis? Like, what kind of education would you want to give her? What are some warning signs, things that can happen? What do you guys think?
Like cramping, bleeding.
Yep,
I'm in pain.
yep, definitely.
Could it rupture the sac? Or
Yes, yes. Uterine rupture can happen.
Can it cause spontaneous abortion too?
Mm-hmm,
Mm.
definitely. So when is an appropriate gestation to have or gestational age to have an amniocentesis?
After 20 weeks?
After 15. Close.
After 15?
Mm-hmm. Yep. Anything earlier than 15 weeks, first of all, the amniotic sac isn't really even fully like developed, right? So before 15 weeks, we don't even have enough amniotic fluid. The baby is not big enough. Our gestational sac is not large enough to go in and collect any fluid for testing. Um, our warning signs for mom, you guys got most of them. Bleeding, cramping, pretty much any sign or symptom that can be associated with a spontaneous miscarriage or spontaneous abortion. Um, for baby, we can run the risk of developing a club foot because of injury done by the amniocentesis. That's one of the bigger risks for baby with this. Um, what else do I want to tell you about it? Yeah, that's pretty much what I want to cover with amniocentesis. Oh, what would be an indicator for why we would get an amniocentesis?
Genetic abnormalities?
Yes, specifically what like which kind?
Would it be like CF or like Down syndrome?
Down syndrome, and they usually are going to screen or do an amniocentesis if really if there's anything that's flagged. But big ones would be neural tube defects.
Mm.
And then yes, like your Down syndrome. And that is going to be
Um,
like kind of up to mom, right? Like these aren't things that we have to do necessarily. But can be good, can be good to know moving forward with the pregnancy, right?
so you said neural tube and Down syndrome?
Mm-hmm. So what blood test or what marker in your blood gives us an indication that a baby could potentially have a neural tube defect or Down syndrome?
the alpha fetoprotein?
You got it. Alpha
Wow, good
fetoprotein.
job.
Nice.
Bird. Yes. Um, is alpha fetal protein elevated or decreased with a neural tube?
Elevated, and then
The-
for Down syndrome, it's low.
Yes.
Oh, okay. Okay,
So
so
elevated with neural tube
Yep.
and down. Okay.
decreased with Down syndrome. Well, that's down and down.
Mm-hmm.
You can think of it that way.
Yes, that's actually a good way to remember it.
I hate to say it that way.
Unfortunately, it's sad. Yes.
Yeah.
Yes. Hold on, sorry. One more second.
And what was that lab test called? Just a alpha fetal protein. It's
Yep.
like a
Alpha
lab.
fetal
Okay.
protein. Mm-hmm. Yes. So, what is something if we know that mom has a high risk for baby having a neural tube, what would we tell her to increase?
Folic acid.
Folic acid.
Folic acid. Yep, you got it. So this is kind of tying it all together, right? Because it's like we don't just do amniocentesis. That's not a typically scheduled thing. Like we're doing them if mom has an indicator or if baby has an indicator for an amniocentesis. Okay.
Mm.
Um, so I think that's all I wanted to cover on that. Does everyone understand that pretty well? Awesome.
Hmm.
All right, let's move on to the next one.
Oh boy.
All right. What is the formula for Nagel's rule?
Um, isn't it you add a year,
Add
subtract three months,
7 days.
and then
Yeah.
add 7 days? But that timer gave me anxiety and I freaked out. Sorry.
Yeah.
Sorry, it's going to be way easier when you do your test because you can write it out and use paper, your dry erase board, and take your time. With Nagel's rule, it's the first day of the last menstrual period, add a year, subtract 3 months, and then add 7 days. Okay. So in this instance, it would be July 26th of 2021. Is Nagel's rule the definitive gold standard for determining gestational age?
No, it's ultrasound.
No?
Correct. No. And it would be ultrasound. Yes, exactly. Great job. All right, moving on. Ooh, I keep getting my like Zoom things in the in the middle of my screen. All right, there we go.
Mhm.
A variable deceleration is
Dang.
what we're gonna see. So I don't know if like for whoever's not in my class, what I teach is veal chop mine, that like 3 column mnemonic, and I can even send. Let me look up something and I'll send it in the chat so that um that basically outlines like every deceleration lined up with like what is the cause of it and then what is our intervention. So this right here, I don't like that. This one, I don't like that either. I like this better. So here you can see a variable deceleration aligns with cord compression. What do? We need to reposition mom. We're going to reposition mom because we want to get that pressure off of that umbilical cord. And oftentimes it's because mom is in a weird position. Okay. Or something's compressing on the umbilical cord, whether it's baby's position or whatever it may be. So I'm sending this in our little like meeting chat so you guys can save it if you have not gotten this yet. But this is really good because it goes through every single thing. So it has an early deceleration, that's just head compression, and that's okay. It just means that labor is progressing normally. An acceleration is okay. Those are what we want to see on a tracing. And then late decels are a result of placental insufficiency. So we need to execute our interventions, which would be reposition mom, um, administer an IV fluid bolus. Let's see what else. Put administer oxygen if we need to, right? So all those things we would need to take into consideration if there's a late deceleration. But yep, so for a variable, we're thinking umbilical cord compression. So we see accelerations on the fetal monitor. What's the most appropriate? So accelerations are that is that deviation off of the baseline that where the heart rate goes up. And that is an indicator of fetal well-being. Accelerations are okay. We like those. It means that our baby is well oxygenated and everything is okay. So we're going to just document the findings and tell mom that this just means her baby's doing well. Okay. So definitely for the exam, no accelerations versus D cells, and which D cells are bad for sure. You guys all got it. Awesome. We want to know what our baseline is. Great work. Because we can't call something a D cell if we don't know what our baseline is, right? So definitely get at least 2 minutes of a tracing to be able to see what your baseline is. And then from there, we can determine if the baby is reactive or not. But yes, first things first is we need to know our baseline fetal heart rate. Excellent, excellent. So whenever we get a patient in labor, the first thing we want to do is determine our baby's heart rate. So think of it as like you have a patient that comes into the ER and they're unresponsive. One of the first things you're going to want to do is determine, well, first, is airway still patent? But that kind of falls in line with your vital signs. So think about it the same way with the baby. The first thing you want to assess with your mom is the mom's vitals. The second thing is we want to make sure that baby is okay. So we want to listen to the baby's heart rate. At the time with labor, a baby's heart rate is the only indicator of fetal well-being, right? We can't really see anything at that time. We're not putting them into like an ultrasound immediately. So we need to auscultate to the fetal heart rate. So it can be below the umbilicus on the right side. So when you're studying, study your cardinal movements as well as fetal lie, fetal position, fetal attitude. Okay. So can someone tell me what ROP stands for? Just those words, the letters.
Um, I don't really remember what it is, but I know I can see the picture of it from the PowerPoint. It's like the way the baby's positioning, like the
Yeah.
way the baby is.
Mm-hmm. So this would be right occiput posterior position. So right would be along the line, along mom's right side in relation to mom's right. Occiput would be baby's presenting part, which would be the head. So it means head is down. The occiput is what's in front, coming first. Posterior would be the way the baby is turned. So the baby's back is turned and it's towards mom's back. Yes. So what I would do is definitely know those positions, that positioning. Um, Let me look up an ROP baby in utero. Yep. Okay. So let me show you guys this really quick. But I use this picture on my PowerPoint so you can kind of get a better like view of what I'm talking about. So an anterior fetus, the spine of baby is going to be facing out towards the belly, right? Posterior fetus, the baby's spine is in line or towards the back of mom. Okay. Occiput would be just like the head is down, and that's what's presenting first on the cervix. That's what's going to be delivered first. Right would be in relation, here we have it here, to mom's side and mom's pelvis. So baby's kind of curled like this. Okay. This here is a right occiput posterior position, how we would see it in the pelvis. If it was an anterior position, this baby's back would be more turned towards us. Okay. So definitely know that for the exam. That is probably the most confusing part I think about baby positioning. And like I've done labor and delivery for like 7 years now. Even I have a hard time and sometimes get it kind of like whenever, especially because when you've done it for a while, you can feel baby sutures and you can tell kind of where they're laying in mom and where they're coming down. But it's hard to be able to say like if they're ROA or ROP or whatever. But yep, any questions on that? Okay. Yeah, so the awesome guys, the amniotic fluid should be clear, almost colorless, and containing little white specks. The little white specks is just vernix from the baby. That's normal. Okay. If it was dark and amber in color, that could indicate some type of infection. Milky, greenish yellow containing shreds of mucus is meconium stained fluid, um, which is an indicator of fetal oh my gosh, what's the word? Distress, fetal distress. Cloudy greenish yellow and containing little white specks. We don't like greenish yellow. Anytime it says green with meconia, with amniotic fluid, we're thinking meconium, and that's not good. But yeah, you guys all got it. Great work. So with this one, we need to know the causes of our variable D cells, right? And that goes back to that veal chop mind. So our variable D cells are caused by cord compression. So we need to get pressure off that cord, and the best way to do that is to change mom's position. Okay. Stopping oxytocin infusion is not a bad idea. That's probably the second thing you would do if you move the patient and the variables don't stop. Okay. But we want to first try and change the mom's position because that'll take us like 2 seconds, and most of the time that's the fix with variables. Great job. You guys are awesome. Yes, if mom is having back pain, it is because she is in an OP position. Let's go back to that picture. So if we look here on this left-hand side, this is an anterior baby. You see how this baby's head is lining up really well with the shape and angle of mom's pelvis? So that baby's going to be able to descend relatively easier. This baby, this forehead here, this face is going to keep hitting up against that pubic bone. And I know any woman who has delivered an OP baby will tell you it is the worst labor they've ever had in their whole lives. So If they tell you that the baby is sunny side up or looking up at delivery, that's an OP presentation, and they have really bad back labor. So if mom is having really bad back labor, what is a good position for her to be in?
Side?
Side is not a bad one, but there is a different one that's a little bit better.
On all fours?
Yes, hands and knees. Yep.
Good job, Megan.
Hands and
Good
knees
job, Megan.
presentation. Great job. Yeah. So, um, hands and knees basically angles the pelvis and it opens up mom's coccyx so that baby can internally rotate a little bit easier to take that pressure off of that pubic bone or that back, the back. Um, so some moms, if they're laboring OP, especially if they don't have an epidural, putting them on their hands and knees is maybe the only position they're comfortable in. Yeah, that's really good.
That makes a lot of sense from one of my first babies.
Yeah, especially if you had a really long labor, that also contributes to that as well. Oxygenation. So, assessment data by determined by examining fetal heart rate strip from the electronic monitor. Your fetal heart rate on the monitor is going to tell you directly the oxygenation status of your baby. Okay? Because we know that if we're having decelerations, it's usually because of a limited supply of oxygen to the fetus. Labor progress, so that is like kind of going like advanced because like I can look at a strip and if a mom's having deep variables all of a sudden out of nowhere and she's a multip and has had multiple babies, in my head I'm thinking, "Oh, she's probably progressing and then she might be ready to have a baby soon." But we can't rely heavily on that to assess our labor progress. Oxygenation is what we're looking at whenever we're reading fetal heart rate tracings. We need to check this mom. This is not her first delivery, so multiparous means that she's had babies before. Um, if she says that she has the urge to push or to poop, that's in the same realm of that she has to push because her baby and she's complete. What is our the name for that urge to push? What kind of reflex?
It starts with a K. Does it or no?
Starts with an F.
Oh, I meant Ferguson?
Yes, Ferguson's. Yes,
Okay.
good job. Excellent. Yes. So your Ferguson reflex is what is going to be that reflex and that strong, strong, strong urge to push. It's and moms often say that they feel like they have to poop. That's very similar. So your fetal presentation refers to the fetal body part that is going to enter the maternal pelvis first. The relationship of the presenting part to the maternal pelvis means I'm assuming this is definition is meant for engagement. So the fetal body part that enters the mom's pelvis first is going to be your presentation. Um, Whether or not that body part is applied to the cervix would be engagement or not. Hypotension. Excellent job, everybody. Yay. Yeah, so the biggest thing that we look for and that we're worried about with getting an epidural place is mom's blood pressure dropping and bottoming out. That is the most common and harmful mom maternal complication. What are some things that we do as the bedside nurses to correct maternal hypotension?
Um, would you give fluids?
Yes, you'd give a lot of them really fast. Yes, we are going to give fluid. Are we going to want her to stay sitting at the side of the bed?
No?
No, we
No.
don't, because we're going to want to get that blood flow back to mom's brain, right? So we need to use gravity to help us. So we're going to put her on her left side. Sometimes, too, we'll put a pillow under their hip to kind of even increase that blood flow to her brain. But we don't want to lay her in Trendelenburg. Why would we not want to lay her all the way in Trendelenburg?
I can't remember, but you don't want a pregnant woman in supine anyways, though.
Right, because of supine hypotension. Excellent. Um, for an epidural, that medication we just gave through her spine, her spinal column, that would run the risk of us having what's called a total epidural, where mom is like completely numb basically from her neck down. So we don't want that, right? So we're not going to put her in Trendelenburg because gravity works the same with that medication as it does with our blood. So if we lay her in a reverse angle and she just got that epidural, that medicine is going to start to creep up, and all of a sudden she's complaining of super heavy chest pain, like she feel like she can't breathe, she can't move her arms, and that's really scary. So yeah, those are the things, the interventions that we want to do. If your mom's blood pressure drops, what do we think is going to happen with baby's heart rate?
It'll go down because there's not a good perfusion.
Excellent. Yes,
Maybe.
exactly. Anything that is happening to mom is going to affect your baby. So in the past, whenever it happens at the bedside, which it unfortunately happens more often than not with epidural placement, and mom's blood pressure drops, you're going to see what we call a prolonged deceleration with baby's heart rate. Basically, baby's heart rate is going to be staying down until maternal blood pressure is resolved. So we want to get her on her side. We want to give her the fluid bolus, and we want anesthesia to administer ephedrine. Ephedrine is the medication that's going to bring up her blood pressure.
Mhm.
Okay. So those are our interventions, nursing interventions for an epidural. I would definitely know that for your exam as well. Oh, two umbilical arteries and one umbilical vein. So which is the one that carries oxygen from the placenta to the baby?
Oh, I guess the vein,
So your vein is going to carry food and oxygen from the placenta to your baby. And so what does that mean that the arteries carry?
deoxygenated blood and waste.
Yes, deoxygenated blood and waste. Exactly. So we have the two umbilical arteries and one umbilical vein. So I would know which vessels carry oxygenated blood, which vessel carries oxygenated blood, which is your vein, and then the arteries are going to carry the deoxygenated blood and waste.
So you said oxygen from placenta to baby.
Yes. And that is carried by your vein, by the umbilical vein. Awesome. 150. Yep. So this is just about knowing your normals. So 110 to 160 is our normal fetal heart rate. A softening of the cervix. Great job. Good job, guys. Fetal movement that is felt by mom. That is our quickening. So irregular painless contractions that occur throughout pregnancy, what would those be?
Braxton Hicks.
Braxton Hicks, yep. Um, the blowing sound that can be heard when the uterus is auscultated is sometimes like fetal movement. If you're listening to a baby's heart rate and you hear like whooshing sounds, that's sometimes fetal movement, or also like just amniotic fluid and pressure. The fetal movement felt by mom is quickening, and then the thinning of the lower uterine segment. What would that be?
Is that lightning or
So I
no?
think in this case, it's referring to like effacement, because like your
Oh,
lower uterine segment would be like around your cervix, unless it's talking about Hagar's sign. Let me see. Yeah, I think that's referring to Hagar's sign, this thinning and the softening of the lower uterine segment. Multiple select. All right. So the correct answers are uterine enlargement, Braxton Hicks contractions, and a Chadwick sign. So the outline of the fetus via radiography or ultrasound would be a positive sign. Yeah, because we're seeing the baby. The other three are things that we experience only in pregnancy, so that would be probable, but we cannot define or definitely say a mom is pregnant until we see, auscultate, or feel baby move, right? So that would be why these three are correct. So we're gonna have the mom walk around until they subside. If they're so with the timing, I think the key word there is irregular. So if she was having them regularly, like really, she's like feeling them almost every 2 minutes or whatever, then we would tell her to time them. But at the 36-week point, if we're gonna see if they're gonna go away with like action, so walking around, taking a hot shower, drinking a lot of water. Maternal and fetal blood are never exchanged. Correct. Good job. Kind of a little tricky question thrown in there for you. Last one here. Yep, number of times a woman has been pregnant. Awesome. Good job, everyone. Way to end it on a high note. Okay, so that it finishes up our Kahoot game. So I wanted to give you guys some time to open up to just any questions or things that you were confused on or that you wanted me to go over more in detail.
For me, I'm just still grasping like Hagar's sign and I got Chadwick's sign and I think Goodall's sign down, and then like definitely the positions of the baby.
Yes. Um, yeah, so I would know definitely the differences in all of those. Um, which those can be like, I don't know if you use like flashcards, but sometimes I'll like do flashcards, at least when I was in nursing school, and like kind of have somebody quiz me on them so that you just get that repetition of reminding yourself what each one means. With the positioning, I think it's really helpful to look at pictures because it's really hard whenever you're just kind of like trying to think or think about it where each thing is going to line up and what that's going to look like. So I would use some graphs and pictures for sure whenever we're studying those. Let me see if I can find a good one that I like.
What about the bellotment too? The bellotment sign, did
Mm.
I say it right?
Yes, you did. So what is bellotment? Do you guys remember?
I actually don't
Um,
remember.
it's not the purplish bluish cervix. That's Chadwick, right?
Yeah.
Right.
Okay. Um,
Ooh, I'm downloading this. Oh, yeah.
no.
So what happens is um so this bellotment is whenever a provider can feel fetal movement or feel like the baby when they're performing a vaginal exam. Okay. So if we say like that a baby is bellotable, it means that we're able to like feel and move the baby up and off the cervix. We can almost like feel that fetal movement. It usually happens around 4 months gestation. And it's just like palpation of the fetus by pressing like the finger into the vagina and kind of like tapping gently. It's not done super frequently, obviously, because we don't usually do cervical exams like that until mom is further along. Because if you're messing with the cervix in that capacity, you can increase a mom's risk for preterm labor. Um, but by pushing on the vagina and tapping gently, it can move that fetus up and down, and you can like kind of feel the baby through palpation. So that is more like an exam done by a provider allotment. So basically, just a way for them to feel the fetus.
Okay. I do have another one. So can you just elaborate a little bit more? So like if we see a question that has like regular contractions or irregular, so when they're like irregular, we're not kind of doing kind of like any like invasive stuff like with baby. We kind of want to like have mom do stuff like on her own to kind of see if it is like walking or resting or
Yeah. So, with contractions, like if you see a question on your exam that says a mom is presenting in the OB department, she's a first-time mom, she's 38 weeks, she's reported irregular contractions lasting for up to 48 hours. You perform a cervical exam and she's closed. There's no change in her cervix.
Mhm.
Um, and what would our indication, like what would we tell her to do? We would tell mom to drink a lot of water. Sometimes we tell them to lay on their sides. Other times we'll tell them like get up and take a shower, go on a long walk, move around and see if that causes the contractions to go away. The biggest thing and the biggest difference between irregular contractions versus real contractions is is the patient making cervical change? Okay. So true labor, those contractions are not going to go away with rest. They're not going to go away with hydration, and they're not going to go away with movement. True contractions are going to keep coming regularly, and they're also going to cause mom to have cervical progression or cervical change, which is the biggest thing that I want you guys to take into your exam, as far as the difference between irregular contractions versus real contractions. Um, so if the question kind of says, like, we monitored the mom for a couple of hours and she made no cervical change, those would be considered not true labor contractions if they're not making mom change her cervix. Okay.
Okay. Thank you.
Um, but yeah, I would definitely focus on whether or not those contractions have caused cervical change because that's our best indicator if mom's truly in labor.
Will there be pictures on the test that we have to like?
I don't think so, no.
We have to kind of memorize some of these images.
Yeah. Yeah,
Okay.
definitely. Yeah, there's not
Um,
really pictures on the exam. I don't even think on the exam there's really like fetal heart rate tracings. Just know your terminology whenever it comes to decelerations. Kind of how it was similar with like the Kahoot, like how it said like, oh, baby's having variable decels. What does this mean? Kind of like
Mhm.
that.
Okay.
What other things do you guys
yeah,
have?
just one more for me. I'm sorry. The Hagar sign you said is thinning of the lower uterine segment, and that's different than effacement, or is that, did you say that was the same?
So, that is different than effacement. Let me see.
I think effacement's the cervix, correct?
Effacement is your cervix. Yeah. The uterine segment would be your Hagar sign. So, yeah, at first I misspoke because I was confused what that Kahoot was meaning. But your Hagar sign is the compressibility and softening of the lower uterine segment. Okay. Your effacement is the thinning of your cervix. And then what is our Chadwick's?
That's like the bluish purple on
Yep.
the cervix.
The
Okay.
bluish, the bluish discoloration of the cervix vagina. And then what is your McDonald's sign?
I haven't even heard of that one.
No worries. I don't think you guys are really going to get tested on this. Um, it's basically alluding to like your fundal height. It's just another thing for fundal height.
Oh, okay.
So how do we measure fundal height in pregnancy?
Oh,
Is it how
that
many gestations, like weeks you are?
Uh-huh. And how do you like from where, what point to what point?
it's like the pelvic.
I think 20 weeks is, go ahead, Megan.
Yeah, so from like I can't hang on. From like this area up, sorry, my camera, and then up to, is it up to the belly button?
So it's going to be the pure pubic bone, and then up to the top of the fundus. We start measuring at around 20 weeks. And then your fundal height should be the same centimeters as you are gestation. So if I'm 24 weeks pregnant, my fundal height should be 24 centimeters.
Okay.
So if a
So
mom,
bundle height should match bundle your gestation weeks.
yes.
After
So
20 weeks, though.
after
From
20
20
weeks.
weeks
Before 20 weeks, we're not really measuring fundal height because your fundus is too small. And at that point, before, your fundal height can vary per person. But after the 20-week mark, it should be relatively standard.
So, and I don't know if we're going to be, we're probably not going to be tested on this, but just I'm curious, like what happens if it's like too big? Because I had too small, so I know what happens with that, but if it's too big.
So if it's too big, that can indicate that we have a mom that may have a large for gestational age infant. It could mean that she has too much amniotic fluid, so polyhydramnios.
Okay.
Pretty much anything that could increase the uterine size based on baby's body mass or underlying like fluid content or something like that. If a mom has a twin gestation, her fundal height measurements are going to be totally different than a singleton pregnancy,
Okay.
because there's two babies there.
Yeah.
So,
Yeah.
yeah, that can cause that. Um, but yeah, we're not really going to that much in detail, but that's a really good question.
Do you know for our math, I know, is it just going to be the math that we've done before, or is it going to be like the medications like oxytocin? And should we?
I am not sure specifically, but I
Okay.
think it is all related OB to OB math. So you guys did your like OB math calculations assignment.
Mhm.
So there's questions that are similar to that where it's just standard conversions and like getting MLs and stuff. I'm not sure if there's a question about oxytocin or magnesium on this exam or not. I can't
And
remember.
just because we haven't had one yet, and we haven't had one yet, and even on the quiz we did, we didn't have one. So I was just curious.
Yeah, I'm not sure if there is on this one yet or not. I think that we may have one in exam two, but I don't think we
Okay.
do that now. But don't take my word on it. Definitely review that. Because yeah, I cannot tell you for sure, for certain.
Okay.
Okay. What else do you guys have?
We can talk about the stages of labor.
Yeah. So let me pull up my PowerPoint. What is our first stage of labor? When does it start and when does it end?
When she's
Contractions
in
and then birth
centimeters.
the baby, like when the
Yes.
baby actually comes out.
Yep, exactly. So your first stage of labor starts with contractions and it ends with the birth of your baby. What are the phases that are within that first stage of labor? There are two phases.
The Latin labor, is that the first?
Yep, uh-huh. And then when does that start?
When she's I don't know.
Yeah, you got it.
At
You're
the
right.
contractions?
Yeah, when your contractions start. When does your latent phase end and your active, which is the second phase, start?
When you're 6 centimeters dilated?
Yep, bingo. Great job. Great work. Yes.
What
So,
was that? Can you repeat that?
yeah, so it goes your latent phase starts with your contractions and it ends when mom is 6 centimeters. Your active phase starts when mom is 6 centimeters and goes until she's completely dilated. Okay. And that's all within your first stage of labor. Your first stage of labor is the longest stage of labor, typically. When does your second stage of labor start then?
Birth of the placenta?
You're getting ahead of it by one. You're missing
Oh,
something. You're right.
Is when the baby enters the birth canal? No. I got confused on this when I was
Isn't it
trying to
4 to 6
study.
hours after birth?
So
No.
that is your fourth stage. That's towards the end. So your second stage of labor, right? Think about it. So our first stage ends when mom is complete. So when would our second stage start?
Immediately after that.
It's the same. It's the
Oh,
same. So
I'm
your
confused.
I was cheating. I was cheating there.
it's all right. Your second stage is going to start when mom is complete and ready to push. And when does second stage end?
When the baby comes?
Yeah, when your baby's
Okay.
born. Yeah, you got it.
So mom is fully dilated, ready to push. Baby comes out.
Yep, that's your
The
second
second
stage.
stage.
Yep.
But I thought it was the first stage because first stage ends with
So your first stage ends when your mom is complete. Okay. So that's when your second stage, when your mom is
Then
beginning,
it transitions to
and then
second, I think.
it transitions. Uh-huh.
so when she's at 10 and now we're ready.
We're
She's
pushing. We're in second stage.
second stage.
And then
And then
that
the
ends with the birth of the baby. So we have our baby. So then what is our third stage?
placenta.
Yep.
Placenta?
Birth of the placenta. You got it. And then that means our fourth stage is what?
Shayna.
Do you
Four
have
to
it,
six
Shayna?
hours after birth.
Uh-huh. That is your recovery period, which is typically, yeah, 2 to 4 hours after birth. Your first 2 hours after delivery is your fourth stage of labor. Because we still need to consider mom in recovery as she's still like we can't just be like, all right, you had your baby. See ya, you're good. Have a great day. We got to still recover her and keep an eye on her for a while to make sure she doesn't bleed. So, yeah, so let's walk through it again. So, our first stage starts whenever mom is having regular contractions that are causing cervical change. Okay. You start in your latent phase of the first stage of labor. That latent phase goes until mom is 6 centimeters. At that 6 centimeter point, she is in active labor, the active phase of her labor. And that goes until she is complete. Once mom is complete and ready to push, we're in our second stage of labor. Mom is pushing, and it ends whenever the baby is born.
Okay.
Then our third stage is just delivering that placenta. Fourth stage is our 2 hour recovery window.
Okay. I have to review that again, but yeah.
Make
Do
those.
Stage
you
3 or
know
4
when
I've got. It's 1 and 2. Like where, yeah. There's overlap there.
There is. So that's the most confusing part about the first and second stage is the end of the first and the beginning of the second are basically the same because you can't really like you can't say when mom starts pushing because like we've had it before where moms will just start to bear down when she's only 8 centimeters dilated, you know? So we have
Hmm.
to go based on cervical effacement and dilation. Um, can your mom feel like her Ferguson reflex during the first stage of labor?
Yes.
possibly?
Yes, she can. So
I
moms,
did. I did. So yes,
yes,
absolutely.
you're like, I speak from experience, guys. I know. Um, yeah, moms can just feel that urge to push as early as like 6 cent. I've had moms say that they feel pressure when they're only 6 centimeters dilated.
Hmm.
So our Ferguson reflex isn't even a good indicator of if she's in second stage of labor or not. We always have to go based on cervix.
Okay.
And you said the fourth stage was 2 to 4 hours after birth, correct? Not 1 to 2.
It is usually only 2 hours after.
So just two.
It's two. Mm-hmm.
Um, I know like there was some questions when I did some NCLEX questions about like the uterus needs to be firm.
Mm-hmm.
We have like no, I know we need to know that it needs to be firm, like it can't be boggy or soft.
Right.
But do we need to know that's all we need to know about that? We don't need to know like afterward, like how long after we have to feel for that.
Um, so as long as you know that you need to recover your mom for at least 2 hours and you know that a boggy uterus is a risk for
Hmm.
mom, I feel like the question you're asking
Hmm.
is going to be more exam two content whenever we get into like complications with labor and delivery, right? Because that's going to be the next step
Okay.
in the
Hmm.
learning. Right now, we just kind of covered standard delivery, labor patterns, fetal heart rate monitoring. The next
Hmm.
exam, we're going to focus a little bit more on abnormalities after delivery, bleeds, what can cause hemorrhages, which we did talk about that a little bit in week 3. So, know what can cause your fundus to be boggy, right? Which would be,
Not abbreviation. I know it abbreviates sick. Is that one of the risks? Is that one of the reasons they do hemorrhage?
what was that? I'm sorry, you cut out a little.
Um, it's like abbreviated DID. It's a you know what I'm talking about?
I think so. Let me see if I can pull up on my side what I have. Which actually, I think we might be getting ahead of ourselves. Yeah, I think we are. We just need to know for this
Okay.
exam Just know for this exam that your fundus needs to be firm and that like we need to be monitoring mom for 2 hours at least after delivery.
Okay.
We don't really get into like bleeds and complications with labor until week 4. So you'll learn about that like, right after your exam. Yay.
So do we just notify the provider if it's abnormal? That
Yeah.
would be the
Yeah. If you were to get a question on this exam that was about like a firm versus boggy fundus, if it's anything but firm and midline, you need to call your doc, is what I would assume you're gonna want to do for this exam. But there should not be very many questions on that because, like I said, we have not really covered that content yet. We get into abnormalities of labor and delivery and recovery next week and week 5.
okay. Sorry, that was it was on my in-class question, so I just
That's fine. Plus, I feel like whenever you talk about labor and delivery, it almost would make sense to put the complications like with it. But we're kind of at this in the weeks 1, 2, and 3, just trying to do like the base knowledge so that we can build off of it in the next exam.
Okay.
So I would say exam 2 is going to have a little bit more of your um, complications with labor and your complications with mom and things that you can run into that are abnormal during deliveries or postpartum. This one is going to be a little bit more straightforward. Okay.
well, thank you.
Yeah. Does anyone else have any questions or things that they want to go over? Okay.
Mm-mm.
So I'm gonna just like run through some things that I think would be worth your guys' time to study. I know Shayna that I showed you in our class the announcement that has the blueprint in it. I'm gonna show them really quick. Um, Let me pull up my Canvas here. I don't know if your guys' professors showed you this announcement, but I want to definitely show you because I think it's worth looking at. That same announcement that you guys have for your review sessions that your professors have been updating um, every time there's a recording or somebody else has had a review session. This one here, this announcement, your exam 1 study session schedule and study material and recordings. If you go in here, this will tell you that there are 5 math questions on the exam. See your OB math announcement for math resources and practice. So looking at that OB math announcement is going to be a good idea. I want you guys to look at this exam 1 blueprint because it tells you basically the concepts or topics that are within the exam. Okay. So this, if I was making a study guide, right, I would definitely go through these things as like priority things to study. Okay.
Okay.
Because this
Oh
is
yeah. Those 5 P's is what, like position. Oh wait,
That's-
passenger, position. The first one's like mom, but it's not a P. It's like a P.
It is a P.
P.
It is, it's a passageway, I
passive.
think.
Passage. That's it. Yeah.
Passageway, passenger, position, and is it physiological or
Psyche, so your
your mental?
psychological and your power.
Power. Yeah. Okay.
Yeah, know your 5 Ps. Know
Okay.
those 5 Ps. Let's see what other ones here. Um, Signs and symptoms that a mom is being abused. Things that you would look for as a bedside nurse taking care of a patient.
Is it like the honeymoon phase and then
So
like
yes,
that?
how would a
The
mama
stages?
like present? Um, If you're in the
Nervous?
room with the patient, like, well, yeah, she's nervous. She's making limited eye contact. What could you also see like on her, like physically? How would mom present?
Mom, how'd you get that black eye? Oh
Right.
my God.
Yeah. Oh, I opened a cabinet really hard,
Hmm.
you
Some
know?
strong cab. Yeah.
Right.
Yeah.
Or
Yes.
her clothes, she doesn't look well dressed.
Yes, definitely.
Yeah.
She's looking like she's not being taken care
Like
of.
hygiene too. Yeah.
Yes. So
Okay.
I feel like
that.
also what another sign is like when the mommy, hold on, mommy. It's it's when
Oh,
the partner like they answer all the questions like instead of the like the actual
Yeah.
question, if that makes
yes.
Yes,
Overbearing.
100%. They won't leave the room with the patient,
Hmm.
like alone. So go through that. Genetic issues, we talked about the alpha fetoprotein. We talked about if it's elevated, that's a neural tube defect indicator. If it's low, that's for Down syndrome. We talked extensively in our Kahoot game about the functions of amniotic fluid, placenta, and umbilical cord. Definitely know that. We went over Nagel's rule. Um, know your G and P's. So be able to say like the entire thing, the GTPAL, right? If we give you a question that's like, this mom has had this many losses, she has this many term babies, this many preterm babies, know how to put those in the GTPAL format. Um, Fetal assessment is going to mean your fetal heart rate tracing. Like, what is your D cells? What is it indicating of? What is our intervention? Okay, let's see.
You said the accelerations and decelerations for fetal
Yeah,
assessment?
for fetal assessment. Yep.
That's going to be the veal chop mine, right?
Uh-huh.
Okay.
Yep. This down here, let's see. Know your normals for your amniotic fluid volume.
Oh, what are your normal
I
volume range?
re I remember that from the first week.
Let me,
Oh,
you remember that?
It's like, is it 5,000? 5,000, is that the number?
Let me hold on. I don't want to tell you wrong because
I
I
know if it's too high and too low,
so if it's too high, what is that called?
oh, you said it
they might
earlier.
have like gestational
Yes,
something,
what's the
gestational
word? What's the
diabetes or
word for
something.
it?
Amnio, ooh, you said it earlier and I don't remember.
Polyhydramnios.
Oh my God. Okay. Say that one more time.
Polyhydramnios.
Polyhydramnios. Too much fluid. Okay. Yeah.
And then
Or a lot of fluid. Yeah.
oligohydramnios is going to be not enough.
Polygo.
Okay.
Oligo. OLIGO.
Oligo.
I
Okay.
gotta look them
Okay.
up.
My computer is like loading super slowly because I have a picture
Okay.
that I want to show you
So
guys.
we don't need to know like the mLs.
I
I think
would.
it was in the slide. It was in the slide. I don't, my,
I would know your MLs because that could be a good question. Like if a mom goes on the ultrasound and her amniotic fluid volume is blank, what does that mean? You know?
Fluid.
did they go by gestational weeks of how much fluid should be in there?
Yes. But for our purposes, let me see where my slide is because I've got a good picture.
So is it less than 5 centimeters?
Ooh,
It is
okay.
definitely, yeah, it's something along that.
So it's like what I'm seeing here is like 4 to 6 weeks is 20 mLs, 20 weeks is about 350 mLs, 37 weeks is 700 to 1,000 mLs, and at 40 weeks you're at 600 mLs ish.
So it can like kind of it can change. Yeah. Yes,
Okay.
let me hold on one second. Let me find my PowerPoint. Why can't I find this? I have it because I just don't want to tell you guys the wrong information.
Mhm.
Amniotic fluid. Here it is. Yay, found it. So, oligohydramnios is having less than 300 mLs of amniotic fluid. So that is having too little amount of amniotic fluid. Having too much would be having more than 2 liters of amniotic fluid would be
2
polyhydramnios.
liters.
Okay.
That's
And
And
is
almost,
then
this
that
a
it,
certain gestational age?
no, not really. I think that's talking about more into the third trimester. But if they're asking
Okay.
a question about it, it shouldn't get that specific.
Okay.
so if you have like, and this is like further in than we probably need to go, but just curiously, if there's too much fluid, does that like just smush the baby? What happens? Or does like can you rupture?
So having too much fluid is usually not is so having an excess amount of fluid doesn't necessarily mean something for a baby. It can lead to intrauterine growth restriction in extreme cases. But the reason
Okay.
we worry about polyhydramnios is because it is usually something that accompanies something else. The most common is gestational diabetes.
Hmm.
So
Oh,
if a
Yes.
mom has gestational diabetes, a lot of times she has excess amount of fluid. So that would be something that like their provider would see and be like, you're measuring with a lot of fluid, and we kind of want you to deliver this baby because even if she passes her glucose test, it could mean that she's developing something else or something else is going on with the pregnancy. So it's more of an indicator of maternal um this not distress, but like that there's something going on with mom. So we're gonna want her to deliver early.
okay. Mm,
Yeah.
okay.
Oligohydramnios, when they have too little amounts of fluid, typically is intrauterine growth restriction, is what we can see with that.
Okay.
You guys
Okay.
should also know, um, like we talked about our cardinal movements, we talked about that. Non-pharmacologic strategies to reduce discomfort, like what is your gate control theory? Like providing counter pressure some or to mom's lower back, right?
Hmm.
Fetal heart
Wow.
rate patterns during labor, early and late variable decelerations. Um, yeah, so go off of this blueprint as you're studying to try and help narrow down the information a little bit more. Some of them are a little bit broader of topics, so focus on like the bigger points when you're studying. Okay.
Okay. Have you ever had anyone who um um couldn't make noises during labor and birth?
Yes. Um, because I live in Ohio, and my first labor and delivery job was with Amish country. So I worked with the Amish a lot. So I was used to women walking in being 10 centimeters dilated, and you would think they were just on their way into the grocery store. Like it was crazy. The Amish are very stoic and they're very quiet and they're very like even-tempered people. It's just part of their culture. So whenever they come in and they labor, most of the time those women will barely make any sound at all. It's kind of interesting.
Yeah, that's wild to me.
Hmm. Yeah, I don't work as much with the Amish anymore, but I still do. I'm still in the same area, so I do every now and then, but it's still true. Yeah, a lot of them are very quiet during labor.
Oh wow, what an experience.
It was fun. It was really
Yeah.
cool. I like working with Amish.
It's just they're like, let's get it done and go.
Yep, they're like, here I am. This is my 20. I helped deliver a lady's 21st baby one time. She was 46
Wow.
and had been pregnant since she was 19 years old.
Mm, mm, mm,
Yeah.
mm, mm.
Pretty crazy.
I have to go, but thank you so much for this review. I really appreciate this. This is great. Thank you.
You're welcome. I'm glad you guys could come. If you have any questions at all, just reach out to me. I will be posting this so that all your professors will have it so you can look back on it if you'd like. Okay.
Okay, also I want to
All
give
right,
a shout
thank
out
you.
to Fatima because she kicked butt during the Cahoots game, so
She's you guys all
thank
did
you.
excellent. Yes.
Yeah,
Great job though. Great job, everyone. This is
thank
really fun.
you.
I'm glad
Awesome.
you guys could
Thank
both come.
you.
Thank
Yeah,
you.
you're welcome. Have a good one.
Bye.
Thank
You too.
you.
See ya.